attract and activate neutrophils. Neutrophils, they express two important receptors, CXCR1, CXCR2, and they respond to the neutrophil chemoattractants through these receptors. So we examined several of these neutrophil chemoattractants like CXCL1, CXCL2, CXCL5, and CXCL8. And we compared different uveitic entities. So you can see that CXCL1 was the highest. But look at the levels. Look at the levels. VKH is colored yellow, sarcoidosis green, Behcet blue, HLB27 light blue. The levels are highest in Behcet and HLB27 uveitis, which tell us that the role of neutrophils is most important in Behcet and HLB27 and is not existing in VKH and sarcoidosis. So we learned from this study, published a few years ago, that we can block neutrophils to treat Behcet and HLB27. Is that clear? So comparing the four diseases, Behcet and HLB27 are mediated by neutrophils. Another one that I think I discussed in the VKH lecture, CXCL13, which is a marker for activation of B lymphocytes. That was a biomarker only for VKH. And that's why currently we treat resistant VKH with B cell depleting treatment with rituximab. Then we looked at the T helper 1 chemoattractants, the chemoattractants that act specifically to chemoattract and activate T helper 1 cells. And IB10 was detected at the highest levels, and the levels were highest in HLB27 and Behcet disease. We have a group of chemokines called soluble chemokines, but these chemo attract mainly T helper 1 cells. And CXCL16 is a very important one. And again, it's a T helper 1 chemoattractant. The levels were highest in Behcet and HLB27. So to summarize, patients with Behcet, they have higher levels of chemoattractants for neutrophils, for T helper 1, and also for tumor necrosis factor alpha. So these patients, our patient with Behcet disease, they have neutrophil hyperfunction. And this is very important information that we should know, because this neutrophil hyperfunction is the one that causes endothelial cell injury in the systemic circulation and also in the eye. And they have these patients, they have higher levels of T helper 1 chemoattractants, indicating that T helper 1 cells are involved. HLA typing, we know that there is an association between Behcet disease and HLA-B51, but we never do HLA-B51 typing to diagnose Behcet. Anyone in the room who knows that HLA-B51 is done to confirm the diagnosis of Behcet? We never do it, because the diagnosis of Behcet is mainly clinical diagnosis. So if we look at the clinical manifestations of the disease, it was based on a large number of patients seen in Japan. And you can see that oral ulceration is present in almost all patients. That's why recurrent painful oral ulcers are an important criteria to diagnose. Skin lesions, 87%, genital ulceration, 73%, eye lesions in 70%. Positive Behcet test in 44%. and this we have minor symptoms. So there is no diagnostic lab studies. There is no test to diagnose Behcet disease. It's mainly clinical diagnosis. So we use the criteria proposed by the International Study Group of Behcet disease. The criteria require, as I said, recurrent mouth ulceration as an essential symptom. It is an essential symptom, plus any two or more of the following: genital ulceration, eye lesions, skin lesions, and a positive pathology test. We don't rely much on positive pathology test. So it is known that the eye manifestation usually follow oral ulceration. The ocular inflammation in patients with Behcet disease develop in about 70% of the patients. And this, of course, data that are coming from Japan. It appears later than oral ulceration. It is bilateral, rarely unilateral, but usually we see that the disease is more aggressive in one eye compared to the other eye. Very important to keep in mind. Behcet is non-granulous inflammation. If you see a patient, I have seen these cases, seen elsewhere with bottom fat KPs, and given the diagnosis of Behcet. Behcet is non-granulomatous. If a patient has bottom fat KPs or iris nodules, this is not Behcet. Is that clear? It is non-granulomatous. And the inflammation is recurrent and is explosive. I like this term, explosive, because when you see the patient with active Behcet uveitis, the eye is full of cells, the retina, a lot of infiltrates, hemorrhages, severe edema. If you do fluorescein, a lot of leakage. It's an explosive inflammation. So hypopyon is seen in about 1/3 of cases, and the presence of hypopyon is reflecting neutrophil hyperfunction. Severe vitritis is common. The major cause of visual loss and will cause retinal atrophy, optic nerve atrophy, and sclerosed vessel is recurrent episodes of vaso-occlusive retinal vasculitis. That's why we always say that we need, if the patient had an attack, we need to suppress the inflammation as soon as possible and to prevent relapses by adequate treatment. Retinal infiltrates, or we call it chalky white retinitis, are common manifestation. In fact, retinal infiltrates, as I'm going to show you, are very important sign of a flare-up. It can be the first manifestation of a flare-up when you do fundus examination. Cystoid macular edema is common, and inflammatory retinal vein occlusion, as I'll show you later, is common. Hypopyon, as I said. Now, whitish or chalky white infiltrates are very common. It can happen anywhere in the fundus, and it can affect the fovea. We have good number of patients like this. And it's an important cause of visual loss or loss of the macular function when you have, because when it heals, it will leave retinal atrophy. And you can see it also in the periphery. Frequently, these infiltrates are misdiagnosed. Another case of retinal infiltrates. These retinal infiltrates are pathognomonic for active Behcet disease. I'm showing you many cases. Retinal infiltrates can be mixed with hemorrhage, and look at fluorescein. It's pathognomonic. Another case with retinal infiltrates. Retinal vascular sheathing, as you can see here, indicating vasculitis. Vascular sheathing. We are conducting a study to investigate patient, to write a report about our patients with retinal vasculitis. At King Abdul University Hospital, we have more than 150 patients. And our inclusion criteria to diagnose retinal vasculitis, you should have vascular sheathing. Vascular sheathing is a hallmark feature of retinal vasculitis. It's not only fluorescein angiography leakage. You can have fluorescein angiography leakage in patients with ischemic retina, like diabetic retinopathy or vein occlusion. To diagnose vasculitis, you should see vascular sheathing. So this patient, he presented with mouth ulcers, but in addition, can you appreciate vascular sheathing? I don't know, this pointer is not showing. So the patient had vasculitis due to Behcet disease. But in addition, the patient had manifestations suggestive of inferotemporal branch retinal vein occlusion, because you can see the inferotemporal vein is congested and tortuous, suggesting that the patient had, if you see vascular sheathing with manifestations of branch vein occlusion, this is inflammatory branch retinal vein occlusion. And if you diagnose inflammatory vein occlusion, it is Behcet disease until proved otherwise. And if you do fluorescein for this patient, you can see delayed filling the inferotemporal vein, confirming the diagnosis of inflammatory inferotemporal branch retinal vein occlusion. Is that clear? Another patient with inflammatory inferotemporal branch retinal vein occlusion. I never forgot this patient. This patient was at high risk to become blind. And he presented with vasculitis, as you can see. And on fluorescein angiography, there is again delayed filling of the inferotemporal vein, supporting the diagnosis of inflammatory inferotemporal branch retinal vein occlusion. At the end, with the help of anti-TNF alpha agent, we could save the vision of this patient, and he enjoyed 20/20 vision. Another patient, what is this? These are collateral. Suggesting of what? All of what? All the branch retinal vein occlusion. So collateral similar to the macula is a sign that this patient had recurrent episodes of branch retinal vein occlusion, but at the same time, the patient had vascular sheathing. As you can see, so this patient had recurrent, because the presence of collaterals, meaning that the patient had recurrent attacks of branch retinal vein occlusion. This patient had inflammatory, why did I say inflammatory? Because of the vascular sheathing. And you can see hemorrhages with hemorrhagic infarction. So he had inflammatory branch retinal vein occlusion and due to Behcet. Unfortunately, this patient was seen elsewhere. I didn't show you the anterior part, and he was given laser because he was misdiagnosed as tuberculous vasculitis. There's a big difference between tuberculosis and Behcet. So this is inflammatory branch retinal vein occlusion. This is another patient, again, with inflammatory branch retinal vein occlusion. You can see that there's delayed filling of the supratemporal vein. Another example. Now, this is one of the most recent patients that we admitted. He was one-eyed. He lost his other eye because of complication of Behcet disease. And he presented, as you can see here, with vascular sheathing, hemorrhages involving the supratemporal retina, indicating that he had inflammatory vein occlusion. Many years ago, I was giving a lecture about Behcet in Italy in Venice, and one of the colleagues, she asked me, Dr. Absar, when should we say inflammatory vein occlusion? I told her it's simple. If you have manifestations of vein occlusion, in addition to sheathing, this is inflammatory vein occlusion. I think it's clear. And this patient, this is the optus. And the optus is very clearly showing the sheathing, also the sectorial distribution of hemorrhage. So this sectorial distribution of hemorrhage in the supratemporal quadrant is a sign of supratemporal branch vein occlusion. Is that clear? In fluorescein angiography, again, we had confirmation of that there is delayed arteriovenous transit time in the supratemporal quadrant because the patient had this. This patient, later on, he had, by repeating the fluorescein angiography, because we could see that he swallowed new vessels. So angiography showed severe retinal ischemia. The patient received laser foot coagulation, received anti-TNF alpha agents, and Infliximab. We are still treating him with Infliximab, and because also he had also severe macular edema, but luckily we are keeping his vision at 20/20 because of anti-TNF alpha agents. So this is another patient, but with CRVO. But can you see here vascular sheathing? So the patient had CRVO, second to which disease. So the message here, if you see inflammatory vein occlusion, it is Behcet disease until proved otherwise. So as I said, macular edema is common in these patients, and this patient no light perception. نحمد الله ونشكره. احنا currently we don't see this picture because we have effective treatment with anti-TNF alpha agents. We don't see any more patient with optic atrophy, retinal atrophy, white sclerosed vessels, but that was common in the past. Now the treatment, as I said, our goals in treatment is to reduce the number of flare-ups and to make each flare-up as short as possible to preserve retinal function. In the past, steroids were used extensively in Behcet disease. And unfortunately, we still see patients with Behcet treated in important hospitals with steroids alone. But I put this in yellow. Can you read this? Systemic corticosteroid monotherapy must be avoided. You cannot prevent blindness in patients with Behcet uveitis with steroids alone. You cannot prevent blindness in patients with Behcet uveitis with steroids alone. Is that clear message? You can use steroids for a short time in addition to other drugs. But anyhow, currently, there is a very limited rule for steroids. In fact, our Japanese colleagues, they never use steroids for Behcet disease. And currently in our clinic, we are doing the same. Cyclosporin is an immunomodulatory agent and is effective in patients with Behcet disease to reduce the flare-ups. However, it's not 100% effective. And the starting dose is 2 to 5 milligrams per kg body weight divided into 2 doses. And we used to use it in addition to systemic corticosteroids. As you know that it blocks interleukin-2, which is a potent T-cell mitogen. Many side effects, therefore we don't use it frequently. Most important is renal dysfunction. Tacrolimus is a drug related to cyclosporin, again, that was used frequently. Imuran Imuran is liked very much by rheumatologists. Rheumatologists, they like Imuran for Behcet disease, but in ophthalmology, we don't use it. Colchicine, as I said, it suppresses the inflammatory function of neutrophils and is the most effective drug for mouth ulcers and genital ulcers and skin lesions. It can change the life of a patient. So if your patient is complaining of mouth ulcers, genital ulcers, your colchicine is very effective. Interferon alpha 2A, in fact, thanks to the late Dr. Manfred Roth from Germany, who started interferon alpha 2A for Behcet uveitis, and of course, he's from Germany. Most of his patients were Turkish. And they showed that interferon alpha 2A is an immunomodulatory drug, is very effective. It's very effective in patients with Behcet. In fact, we wanted to have it in our clinic, but the company is not producing it anymore. Interferon alpha 2A. And because also the experience of some of Italian colleagues that it is very effective also for uveitic macular edema. Inshallah, it will be available, then we can use it. But it is very effective in patients with Behcet disease. And what was of interest is that the patients, after some time of using it, they cannot stop it and they remain quiet. The protocol for using it, our Japanese and Turkish colleagues, they use it at 6 million units subcutaneous daily. Other colleagues, they use it at 3 million units 3 times a week. And I know that pegylated interferon that can be given once a week is available. The side effects is flu-like symptoms. I remember Dr. Manfred Roth was telling that if the patient develops flu-like symptoms, it assures him that the drug is effective for this patient. So the presence of flu-like symptoms is a symptom that the patient will respond. Mild alopecia, leukopenia, itching, autoantibodies, and other autoimmune diseases can develop like autoimmune thyroiditis, but this can be reversed by stopping the treatment. Infliximab now is our first line of treatment for patients with Behcet disease. Infliximab, in fact, was a revolution in the treatment of Behcet disease. Currently, we don't see blindness in patients with Behcet. I'm talking about patients who present to us with still potential vision, emergency room. It allowed us to stop blindness in Behcet disease. So infliximab is a mouse human chimeric immunoglobulin G1 monoclonal antibody to tumor necrosis factor alpha. So part of the molecule is of mouse origin. That's why it's called chimeric. And that's why some patients, they can have anaphylactic reaction to infliximab. It neutralizes both the soluble and membrane-bound tumor necrosis factor alpha and inhibits a broad range of biologic activities of tumor necrosis factor alpha. You remember, at the start of the lecture, I told you, patient with Behcet uveitis, if you analyze the aqueous humor from this patient with active disease, you have high levels of tumor necrosis factor alpha. And this explains why they respond very quickly to infliximab. It's given intravenous infusion, 5 milligram per kg, body weight, over 2 hours, and we start at week 0. Then 2 weeks, we add another dose, loading dose, and then after 4 weeks, we add the 3rd dose. And usually, if the disease was active, we give it every 6 weeks, not 8 weeks. The side effects that you should know before you start, you give the patient infliximab, is that infliximab or anti-TNF alpha agents, they can induce tuberculosis. They can induce tuberculosis. You can activate tuberculosis if you're not careful. So before we start Infliximab, we are very carefully doing tuberculin skin test. Make sure that it is negative. If it is positive, then we can cover the patient with prophylactic INH for 9 months. So before you start Infliximab, you have to make sure that the patient has no latent tuberculosis by doing tuberculin skin test. Infusion reaction can happen because of the chimeric nature of the antibody, and other infectious conditions can happen. It can induce autoantibodies, and we published this before, anti-nuclear antibody and double-stranded DNA, but without any systemic lupus erythematosus manifestations. And it can cause the myelinating disease. Therefore, we are always careful also to make sure that the patient is not MS. And these are a table, an old table that's showing some of the complications that happened from different studies of Infliximab. And you can see pulmonary tuberculosis is among them. So these were conclusions of, we published previously Dr. Sultan al-Rashidi. He was one of our residents, and that was his thesis as a resident. And he collected our cases of Behcet disease that are using Infliximab, and that paper was published in good journal, Ocular Immunology and Inflammation. And the conclusions of this paper was that was one of the first papers published to show the efficacy of Infliximab in patients with Behcet. That Infliximab is safe and very efficient. In fact, it acts very quickly. Next day, patient will tell you that he's starting to see. The Infliximab also controls mouth ulcers, genital ulcers, and other extraocular manifestations. But the patient needs repeated infusions. It is effective also for cystoid macular edema. So at that time, our study confirmed previous studies, small studies that were based on a small number of patients that shows the efficacy of Infliximab for treating refractory uveitis with Behcet disease. Now you might ask me, for how long the patient will need Infliximab? The patient will not use Infliximab for the rest of his life or every 6 weeks, because gradually with time, we can prolong the interval between the infusions to 8 weeks, 10 weeks, 12 weeks, and in good number of patients, we were able to stop it and they remained quiet. And also other patients, you stop it, but after 6 months, they develop flare up, but not as aggressive as before. And then we have to resume it again. These are examples of cases before Infliximab, after Infliximab. Look at fluorescein angiography, the upper one, and then after Infliximab treatment, there is much less leakage. Again, before and after, fluorescein before and after. Cystoid edema also will respond. This is the patient. Remember, I showed you the patient with inflammatory branch, central retinal vein occlusion. And this after Infliximab. I'm still seeing the patient. He has 20/20 vision. So Infliximab was very effective to preserve the retina of this patient. Patient with branch retinal vein occlusion after Infliximab. So this was a very aggressive disease. This patient with Behcet disease, he had multiple patches of retinitis that can be easily confused as viral retinitis. These multiple large patches of retinitis. In fact, one of our colleagues who saw the patient in the emergency room, he thought about acute retinal necrosis, but that was Behcet. with large patches of retinitis. And if you look at fluorescein, this is a good example of explosive uveitis. And after infliximab, we are still following up this patient. Now, he does not need infliximab every 6 weeks. He just take it every 10 weeks. Adalimumab, this is another anti-tumor necrosis factor alpha agent. It is completely humanized. It is given subcutaneous every other week at a dose of 40 milligram in adults. In children, less than 40 kilo, 20 milligram. We use adalimumab in patients with Behcet only in those patients who become allergic to infliximab. But we prefer infliximab because it is much more effective than adalimumab. There were trials to use other group of biologics. Interleukin-1 is another important biologic pro-inflammatory cytokine. But we never had detectable levels of interleukin-1 in the eye of patients with Behcet disease. It's not. We did many times. We never had detectable level. Then there was a company called Zuma produced a drug called gefacizumab, which is anti-interleukin-1 beta monoclonal antibody. And this started, and it was manufactured by a French company called Servier. So Servier, they communicated with us if we can do a part of a trial to try gefacizumab, anti-interleukin-1 for patients with Behcet uveitis. So I communicated with my colleagues in Leuven. In fact, one of them, Professor Jo van Damme. Jo van Damme, they call him the father of chemokines and cytokines because his lab introduced for the first time many. If you go to the literature, Jo van Damme, you will see hundreds of publications about chemokines and cytokines and so on. So, and I discussed with him, and he told me, Ahmed, if you don't see IL-1, interleukin-1 in the aqueous humor, this drug will not be useful. So we did not participate in this study, and after 6 months, in the news, the study was terminated because gefacizumab is not effective. So that means that's why I always give a lecture, the title in meetings abroad, that analysis of the aqueous humor from patients with uveitis, different uveitic entities, for cytokines and chemokines will help us to optimize biologic treatment. Because with biologic treatment, you are targeting a specific molecule. Infliximab target tumor necrosis factor alpha. Tocilizumab is target interleukin-6. Rituximab is targeting B lymphocytes. You need to have this molecule operating. If it is not existing in the eye, so using gefacizumab as an anti-interleukin-1 will be useless. Do you agree with this? So the approach to treatment, of course, for anterior segment inflammation, we use steroids. But that was, I want to come here. Approach to treatment. That was expert panel recommendation that recommended the use of anti-tumor necrosis factor alpha in patients with Behcet disease as a first-line treatment. So infliximab and adalimumab can be considered as first-line immunomodulatory agents for the treatment of ocular manifestation of Behcet disease. In fact, in our department, we use infliximab as a first-line treatment if the patient had posterior segment inflammation. We should not waste time. In the past, when we started using Infliximab in our department, we were first trying conventional treatment, steroids, cyclosporin, azathioprine, and if it fails, we'll move to Infliximab. But nowadays, we use Infliximab as a first-line treatment because now we know that this drug is very effective to prevent blindness in patients with Behcet disease. Thank you very much for your attention. Any questions? There's no overlap. You mean the retinitis. Retinitis is a part of Behcet disease. And for those who do not have enough experience, they might misdiagnose these cases as viral retinitis, like acute retinal necrosis. The diagnosis for Behcet disease, at least with us, is not difficult. Based on systemic manifestations, based on clinical findings, based on fundus phyllosine angiography. And you should not waste time. That's why I think I told you this story. During Morfield uveitis course many years ago, it's one of the most important uveitis courses in Europe. And there was a session for difficult cases. So one resident from Morfield Eye Hospital was presenting a case of multiple patches of retinitis, and he thought that this was viral. They were treating the patient with antiviral treatment. And then I gave my opinion, this looks like Behcet. And it happened by chance. Professor Marwan, our colleague in the Department of Ophthalmology, he went to Morfield Hospital for a visit, and he was in the clinic with them, and they told him, this is a patient with Behcet who was diagnosed by ElAsrar. And then he received the treatment for Behcet disease. So I mean, they did this mistake because in Europe they don't see Behcet disease. But we see Behcet disease is part of our life. We know now, that's why I showed you many pictures, many cases, that retinitis is an important feature of Behcet uveitis. And it can be the first manifestation of a flare-up. We always, when the patients, they come, we have Infliximab clinic, when they come to the clinic, we have a careful look at the fundus to look for retinitis. And sometimes the patient is asymptomatic, but there is a patch of retinitis, which tell us that the patient is having early flare-up, which means that if he was using Infliximab every 8 weeks, we need to give it every 6 weeks.